Hi, my name is Maya, and today I'd like to talk about Planned Use Study Act or PDSA cycles. A PDSA cycle is a very useful tool that helps us work through implementing a change in a structured way. The acronym itself is pretty self-explanatory. We plan a test, do the test, study and learn from what happened, and then act on the results. We recognize that to innovate and find any new way of doing things, we're probably going to experience some failures. One of my wise mentors used to say, when trying something new, it's best to fail small, fail fast, fail often, and fail forwards. For most of us, though, failing is an uncomfortable feeling. But it's important to test changes and to recognize that rarely is the first iteration of a change perfect. Testing changes helps us to learn if the change resulted in improvement or not. Did it work? Testing changes helps us to understand how much improvement is possible. Is this an intervention that makes a big impact or a small impact towards your outcome? And because context matters, it's important to test the intervention in the actual environment that it's intended for. Doing this and transparently sharing results, it allows people time to experience, participate in, and impact change. But how do you actually do this? First, you make sure that your team is ready, and that means having a team and ensuring that you have the right stakeholders represented, that you have a clear idea of what your initiative is trying to accomplish. You've determined your measurement plan and your key driver diagram. Then your team is ready. It's easier for me to understand concepts by using clinical examples. So today I'll use the example of an antimicrobial stewardship program in a NICU. The problem being that a percentage of infants over 34 weeks gestation received empiric antibiotic therapy in the newborn nursery or NICU when they potentially didn't need it. The initiative's aim was that within a year, there would be a 30% reduction in antibiotic use within the first 3 days of life for this population of infants who were born to moms having a diagnosis of chorioamnionitis and or qualified for GBS interpartum antibiotic prophylaxis. We were looking for a 3% reduction in antibiotic use in this population. Now to planning, which involves having an objective, making a prediction and executing a plan. The objective of this particular PDSA is to test a process to identify infants requiring antibiotics using a standardized electronic medical record or EMR note that includes the Kaiser Sepsis Risk Calculator. We thought that embedding the sepsis calculator in the EMR note would improve identification of infants who did not require antibiotics. And to make this happen, we needed a plan that answered the basic questions of who, what, when, where, and how. For this cycle, a standardized EMR note would be used for qualifying infants. We wanted to get just enough data to make sure that this change had a potential to make a difference. We started small. We engaged one provider to this trial for 1 week in one location, our newborn nursery. We identified a person to tally the percent of correctly documented Kaiser Sepsis Risk Calculator scores located in the standardized EMR note using a paper documentation tool. Now that the planning is done, it was time to do the test. We took notes on problems and observations, what worked and what didn't work. We considered things like, did the provider have access to the EMR note? Was the note easy to use? Was the recommendation easy for the providers to interpret? And we kept in mind that if this test wasn't working, we could stop it. For example, if the identified provider found that the note was excessively burdensome to complete, it could be stopped right away without waiting for the entire week. Next up is studying the data. In this example, say 8 of 10 qualifying infants had correctly documented Kaiser Sepsis Risk Calculator scores in the standardized EMR note. That supports our prediction, and by doing the test, we learned that using a standardized note did in fact simplify documentation and improve the efficiency of note writing for providers. And then the A, acting upon data and figuring out next steps. In this example, the team had a pretty well thought out intervention that worked well in their clinical environment. So it was time to expand the test. The next steps could be testing this process on all providers in the newborn nursery for 1 week, or it could have been testing on one provider in one area during the opposite shift. For example, night shift, if this has been previously tested in day shift. All of this sounds easy, but there are some pitfalls to avoid. Remember that if you're going to fail, fail small. The last thing you want to do is to complete a large rollout of education on one tool, only to find out that the tool needed more refining. And by scaling down, I mean scaling down the number of patients or doctors or others involved in the test, go with a thought of sample the next 10 instead of getting a sample of 200. Scale down the location to 1 unit instead of all units. Scale down the duration of the test, 1 day instead of 1 week instead of 1 month, 1 shift instead of all shifts. Pick willing volunteers. Work with those who want to work with you and who will give you honest feedback about what worked and what didn't. Avoid the need for consensus, buy-in, or political solutions, especially in the early testing phases. And don't reinvent the wheel. Instead, replicate changes made elsewhere. For example, instead of creating your own treatment protocol, try to modify another hospital's protocol. Look for the concepts that seem most feasible and will have the greatest impact, and pick the easy changes to try first. Avoid technical slowdowns. Don't wait for the new computer to arrive. Try recording test measurements and charting trends with paper and pencil instead. Reflect on results of every change, not just the ones that work. Too often, people avoid reflecting on failure. Remember that teams often learn very important lessons from failed tests of change. Some of the questions a team should ask themselves after making a change are, what did we expect to happen and what did happen? What were the unintended consequences? What was the best thing about this change and what was the worst? What might we do next? Perhaps one of the most important tips is to be prepared to end the test of change. If the test shows that it's not leading to improvement, the test should be stopped. These failed tests of change are natural parts of the improvement process. And honestly, if a team experiences very few failed tests of change, it's probably not pushing the boundaries of innovation very far. Your challenge now, design your team's first PDSA cycle. You can email me or Karen Fugate with any questions.